discuss about point of care neonatal ultrasound and how this bedside ultrasound is useful in our day-to-day practice. So we will see the cases which are managed on day-to-day basis and how the ultrasound brain, lung, gut and lines has been useful in our day-to-day practice. I'll not cover the topic of functional echocardiography because you already have a fantastic talk by Mohit sir on Saturday evening. So we will just see few aspects about that, but these are the 4 areas we will try to cover. We will also see what are the current limitations about these point of care ultrasound in Indian setups and how we should go about further training component from the national level. This is the famous article from the JAMA Cardiology. The first and most important thing as a clinician, we all have to be expert in inspection, palpation, percussion and auscultation. But now in the last 2 decades, along with these 4 components, we need to also work on insonation. So the bedside ultrasound in neonatology is there since 1990, or I would say since 1985, when a lot of neonatologists were using cranial ultrasound. In German-speaking countries, the hip ultrasound is also a component of their curriculum. In the last 2 decades, the functional echocardiography has become a lot of component of most of the level 3 NICUs. And in the last probably 5 to 10 years, if you open the journals in each month, 1 article on lung ultrasound is available. So what does it mean now? That most of the level 3 NICUs, they have started using bedside ultrasound as an additional 5th tool in their basket. So we have to have a basic first, but along with the basic, I would say that insonation should be part of our day-to-day practice. What is a point of care ultrasound? The point of care ultrasound is a focus test. It is performed by the clinician at bedside. First of all, remember, this clinician is a neonatal physician, pediatric physician who is doing this ultrasound. He is not a radiologist. He is not a pediatric cardiologist. He has some question in his mind, and this ultrasound will give immediate answer. Once he sees that ultrasound, he gets the answer. He wants to apply the management, and that management is life-saving therapy for that baby. And then you can monitor after 6 hours, 12 hours, 24 hours, and then continue the treatment of the baby. That is the full cycle of the point of care ultrasound. If you see, this is Professor Martin from Sydney who has suggested this cycle of clinician perform point of care ultrasound. This is the focused, this is bedside, it's a real time, it's a serial one. It is mainly for function. Remember, dear friends, it is not for structural cardiology. It is not for structural lungs. It is not for structural for the brain also. So for whenever it comes to the structure, you need to involve your pediatric cardiologist, your pediatric radiologist. It is mainly for physiological things. It defines and it redefines your decisions. It targets your treatments. Once you give the treatment, it monitors the response. So this is the full cycle of the CPU, which we need to follow in our day-to-day practice. What are the components of the point of care ultrasound which are useful for us? Ultrasound is useful for diagnosis of condition like, as you know, simple pericardial effusion, pleural effusion, ascites. Ultrasound is useful for critical assessment like IVH, like your, again, cardiac tamponade or pericardial tamponade. Those are the conditions where the baby suddenly deteriorated. At that time, ultrasound immediately helps in assessment. Ultrasound is useful for screening of IVH, PVL. Ultrasound is useful for monitoring of post-emergent hydrocephalus. Ultrasound is useful for prognosis. We'll see in the case-to-case basis. I just mentioned about the role of ultrasound for procedures and therapeutic problems. In neonatology, ultrasound, as we already know that various effusions, we can useful for TAPS, for lumbar puncture, and no need to say that in the last decade now, ultrasound is useful for research component. That means the ultrasound is giving a lot of ideas, and then management is changing, and day to day we will see now lot of papers on hemodynamics coming out in each journal. What are the basic components or which are the systems we are going to screen? This is the cranial ultrasound, lung ultrasound, gut ultrasound. I already mentioned that we are not going to touch on functional echocardiography, which is already covered. At the same time, we will see the lines position, confirmation of line procedures, or insertion of PICC lines. The procedure like suprapubic tap, pleural tap, pericardial tap, and ascitic tap is also a part of your ultrasound. And then ACA flow, MCA flow, and various hemodynamics component. These are the ones which are providing research in the neonatal field. What does ultrasound? These questions comes. These are the point of care ultrasound where the answer is yes or no. You don't want to have too many questions and you don't have too many answers. It's only yes or no. We know that does my PDA is hemodynamically significant? Does the pulmonary pressures are high? Is the cardiac output is low or high? Is the heart contractility is normal or abnormal? Is there any free fluid in the pericardium? Is the IVC full or empty? These questions give you answer yes or no, and you can change the management. Similarly, for cranial ultrasound, is there intraventricular hemorrhage, intracranial hemorrhage, or the Doppler velocities are problematic? These answers we get for the cranial ultrasound. Similarly, we can diagnose RDS, TTN, or meconium by the lung ultrasound. Is there pneumothorax, which immediately acts for the drainage of the pneumothorax? Is there any pleural effusion? I can diagnose the pneumonia. So these are the common questions you will get answered from the lung ultrasound. Again, insertion of the lines and position of UAC, UVC, endotracheal tube, and the PICC lines is the component of the lines. And now, last 4 or 5 years, gut ultrasound is also coming out in a big way to diagnose ascites, to see the gut peristalsis, to see the portal and gas, and associated kidney anomalies also that are useful for the abdominal ultrasound. So to understand these ones, we will go through the cases which are day-to-day cases and how this ultrasound is applicable in our day-to-day practice. This is a 34-weeker baby, which is 1.4 kg. This baby is outborn, came on day 4 of life for deterioration, for apnea, bradycardia, and hyperglycemia. Naturally, your first thought process comes in mind as a late onset sepsis. Baby immediately required ventilation. You can see the baby's blood pressure. For 34 weeker, mean blood pressure is ranging 20-25. So the baby has severe hypotension, poor capillary fill, metabolic acidosis, and high lactate. So clinical diagnosis from your inspection, for your palpation percussion, clinically you are thinking this baby which is presenting as an outborn baby with suspected late onset sepsis, with hypotension, with a poor perfusion, with high lactate. What does the echocardiography, functional echocardiography shows in this baby? If you see the echocardiography in this baby, which is a bidirectional PDA. So this is a classic bidirectional PDA. This is the red is the actual left to right. Inside blue is your right to left PDA. This baby also has a TR and MR as a component of your left ventricular and right ventricular dysfunctions. This is the Doppler of the PDA, which is a bidirectional PDA. So the functional echocardiography in this baby shows this baby has a very high cardiac output. The cardiac output in this baby noted is in between 500 to 600 ml per kg per minute. Normal cardiac output in the preterm after 24 hours, mainly 48 hours, is around 150 to 300 ml per kg per minute. And here you can see the cardiac output is double. So the baby has a dysfunction with a high cardiac output. That means I am dealing here with a severe hypotension, which is a late onset sepsis hypotension, which is in the form of vasodilatory shock. So what my functional echo told me that this baby has a hypotension. The cause of hypotension is a vasodilatory shock with you have a LV dysfunction. From this information, along with management of ventilation, perfusion, oxygenation, antibiotics, I'm going to have a management in the form of which inotropes I'm going to select for this vasodilatory shock according to my unit protocol, whether I want to select adrenaline, noradrenaline, those are the things which we can decide from this case. So the functional echo has helped in selection of these one. And hence, our unit has done a research in the form of cardiac output in late onset neonatal sepsis. What we saw, the gram-negative sepsis, the common organism in our unit is Klebsiella and Acinetobacter. In this baby, if you see the ventricular output in these 31 babies is ranging from 300 to 400 ml per kg per minute, and the value turned out to be 338 ml per kg per minute for right ventricular output, and for left ventricular output is 378 ml per kg per minute. That means the gram-negative sepsis, if you monitor the cardiac output, these babies are pumping more, cardiac output is more, and that is where we need to think about these babies. Similarly, because the baby has the problems of the heart, we decided to do the lung ultrasound. And this is the lung ultrasound of this baby, where you can see the disruption of the pleural line. We'll come to that again in the discussion of lung ultrasound. There is air bronchogram, there is hypotization of the lung, and the Schrader sign. This is a classic Schrader sign. So this baby, along with the heart involvement, there is a lung involvement also. So this baby has pneumonia also. So multi-organ involvement. This is the classic. You can see the hepatization of the lung with the Schrader sign in this picture. Along with this, there is a pneumonic effusion with this baby, which is documented as a part of the lung ultrasound picture. When we saw these pictures, naturally, as a part of your septic screen, you need to do the lumbar puncture. To do the lumbar puncture, we did a spinal ultrasound. This is a simple picture of the spinal ultrasound. You can see this is a spinal canal, this is spinal cord, vertebral bodies. When you put a Doppler, color Doppler, this is the color Doppler, you can identify the vessels. From these vessels, you can select which space you want to do for lumbar puncture, whether you want to go for L2, L3, L4, depending upon the vessels, and depending upon those ones, you can select the site for lumbar puncture. So the site of selection is done by the site of selection of the lumbar puncture is done by the ultrasound. When that done, if you see this baby's ultrasound, this is the coronal view of a foramen maundro view of this baby. What this shows, there is a dilatation of the ventricles with disturbed ventricular line. This is the ventricular lines are the irregular ventricular lining. Inside, you can see there is echogenic material. This echogenic material is naturally the exudate. So this is a classic picture of ventriculitis. So the baby with late onset sepsis, with heart involvement, with lung involvement, there is also involvement of the brain. So meningitis plus ventriculitis. You can monitor this ventricular size by your Levin's index. So this is the measurement of Levin's index. This is Levin's index. This is anterior horn width. I'll come to that discussion when we are discussing the lung ultrasound. And you can do occipital thalamus monitoring also in subsequent weekly ultrasound scan. So this baby has a ventriculitis. Because this baby has a ventriculitis, additional the brain parenchyma search, the brain parenchyma has these cystic lesions which are confirmed as a brain abscess by CT scan. And the organism turned out to be a Bugdolia capsicum brain abscess. That's a report published in IJP. So this baby has not only the meningitis, ventriculitis, there is also brain abscess. Naturally, with this, my duration of antibiotic changes. The antibiotics which we are supposed to give for 2 to 3 weeks, now we need to give antibiotics 4 to 6 weeks with frequent monitoring of lumbar puncture and ultrasound. This is how ultrasound has changed. Hence, the same time, we also did RI in this baby. The RI is a registry index, and this baby's RI showed reversal of the flow. With this baby of ventriculitis, the flow is reversal. That is a case report published in Journal of Neonatology. And hence, our team has done a prospective study to find out the role of registry index in late onset neonatal sepsis. This is the normal registry index in anterior cerebral artery. This is the anterior cerebral artery, systolic and diastolic. Systolic minus diastolic upon systolic is the registry index. What we observe, the babies with a late onset neonatal sepsis have a high incidence of absent or reversal of flow with late onset neonatal sepsis. So almost, you can see, almost more than 50% babies have absent or reversal of flows. And those babies with the reversal, out of that, we lost 4 babies That means the babies with reversal of flow have a prognostically bad outcome. So that is one more marker which is in future publication. Because of this additional thing, our team has done the hip ultrasound, and you can see there is exudate here. So this baby has also septic arthritis, which is confirmed again by the CT scan. So there is a hip involvement. Naturally, the organism, we already show that. Naturally, this is additional point we got from this hip ultrasound, that there is echogenic material and there is a septic arthritis in this baby. So there is a multi-organ involvement. Because of that, we could able to define the baby's duration of antibiotic. Naturally, this baby required intubation, what we discussed initially. So to confirm that endotracheal tube position, we now don't do the X-ray. The simple way to do the confirmation is by ultrasound. What view you need to do? You need to select your arch view. So this is ascending aorta, this is the descending aorta. At the descending aorta, this is the right pulmonary artery. Adjacent structure between the descending aorta and right pulmonary artery, that's your carina. So this is the carina, and this echogenic line, this is called as endotracheal line. So this is ETT line, and that's the tip of the line. So from this tip to the carina, you should measure, you can measure by ultrasound, and you should want at least 1 centimeter. So remember, you can measure the size, you can measure from carina to the endotracheal tube, and this is how you can confirm your endotracheal tube position by ultrasound. You don't need repeated X-ray by this one. So avoid doing repeated X-ray for confirmation of endotracheal tube position. Because this baby required long duration of basic antibiotics, naturally the resident has put the PICC line, and this is the position of the PICC line. If you see, this is a subcostal view, this is the IVC, and this is the right atrium. You don't want PICC line into the right atrium, and you want just below the diaphragm. This is a normal position. The line is in IVC, which is confirmed by the ultrasound very easily. Again, misleading results by the X-ray, that you will feel that your line is below the diaphragm, but sometimes the line is in RA. But ultrasound gives you definitive diagnosis that the line is in IVC. So ultrasound is very useful in this baby for confirmation of the PICC line. Hence, one more study done by our team is the role of ultrasound in late onset sepsis in various organs. So what we found out that near about 45% of the time, brain ultrasound was abnormal in late onset sepsis. 80% of the time, heart functions were abnormal into this late onset sepsis. Almost 30% of the time, lung involvement was there, and abnormal line position was documented in 10% of the babies in that 1 year duration of almost 1100 admission. So what this case has taught us? This case has taught us that this infant with a late onset sepsis with a high output and low systemic vascular resistance, that's where my choice of inotrope, as I told you, depending upon the unit potency, as adrenaline or noradrenaline, we can select after volume replacement. This ultrasound also helped me that other organ involvement, that heart, lung, brain and hip involvement, I could able to define from this case. We could able to define duration of antibiotics. We can prognosticate this baby. We can able to confirm the ETT position, PICC line position, site of lumbar puncture. So many things we can able to do from one case, and hence I think we need to think about utility of bedside ultrasound in our day-to-day practice. Now let's see the second case. This is the baby who is born outside in a primary health center. As we all know that still there are babies in India, they are still born outside and they are coming as 600, 700 grams also. So this baby came to NICU at 2 hours of life with a severe distress. Baby was very pale, poor perfuse, baby required immediate intubation. So this is the lung ultrasound. This lung ultrasound shows, I'll come back to again in the lung ultrasound discussion, this is a thickening of the pleural line. And below this pleural line, these are called as synemonic consolidation. That means these are the subpleural consolidation with whiteout lung, with air bronchogram, and heart shows poor contractility, with whiteout lung X-ray. Naturally, everybody wants to do surfactant therapy because parents wanted to do everything. This is the fourth child after the three-girl child. So parents said that we want to go ahead with everything and give us whatever the possible things are there. Hence, immediately, before giving surfactant therapy, the brain ultrasound, cranial ultrasound done. And can you see this massive echogenic structure here? This is nothing but, you can see this massive echogenic, this is nothing but periventricular hemorrhagic infarction. That means old terminology as a grade 4 IVH. And as a neonatologist, we all know that when you have this preterm who is this 26-weeker, 600 grammer, with this massive bleed, your mortality chances are 60 to 80%. Your morbidity chances are 70 to 90%. And hence, we discuss the family that baby has a high chances of morbidity and mortality. So we need to think properly whether we should go ahead. After the consultation, naturally the parents took withdrawal of support. So ultrasound has helped in the prognostication of this baby. And hence it is very, very useful to think about such scenarios. So now we'll discuss in the next 10-15 minutes about a cranial ultrasound. So the cranial ultrasound, as we all know, day-to-day IVH diagnosis, screening, and intraventricular, intracranial, and cerebral hemorrhage in a micropremy, ultrasound is useful. At the same time, after your grade 2, grade 3 hemorrhage, post-hemorrhagic hydrocephalus, it is useful for diagnosis and monitoring. I just showed you the role of Dopplers. Again, I will come to that points of the Doppler. In cases of asphyxia, we'll discuss that. I just showed you about role of infection as ventriculitis, hydrocephalus, and abscess. So these are the common things we day-to-day use for the cranial ultrasound. And for the cranial ultrasound, if you have a sector probe, which is between 5 to 8 Hertz, or sector probe between 8 to 12 megahertz, then that is good for both. If this sector probe is useful for your cranial as well as your heart ultrasound. That is what is cranial ultrasound's requirement. This is the screening protocol which has been done by our team and which is published in Indian Pediatrics in 2016. A baby who is less than 28 weeks or less than 1 kg, where we should be doing the first ultrasound within 24 hours, the second ultrasound after 72 hours to within 1 week, 4 weeks and before discharge. These are the ultrasound recommended for screening purposes for monitoring of IVH, cerebral hemorrhage, and PVL. As you all know, the cerebral hemorrhage is common. Those babies who are less than 750 grammars or those who are 26 weeker, less than 26 weeker. While the babies who are 20 to 32 weekers or 1 to 1.5 kg, those you should do between 3 days to 1 week, at least first ultrasound, 4 weeks to 6 weeks second ultrasound, and before discharge. So at least 3 ultrasounds you should be able to do in these babies. Those babies between 30 to 34 weeks with the risk factors, you should do at least 1 ultrasound at the first week of life. And that's what another study we are doing at present moment in our unit is a neonatal cranial ultrasound or point of neonatal cranial ultrasound in a late preterms. We don't have a lot of data in India about late preterms and the cranial ultrasound. I think we can think about those ones and we can go ahead because we do have a 35 to 38% the fetal growth restricted babies of these late preterms. Also, we could able to find out some future protocols. So where to find out your IVH? As you all know, this is a coronal view. IVH you will be able to see next to the concave curve. This is the concave curve of the lateral wall of the lateral ventricle where you will be able to see the IVH. So that is where you could able to see IVH as a germinal matrix hemorrhage or grade 1 hemorrhage in this baby. While in the sagittal plane, the IVH of germinal matrix hemorrhage you could see as oval shaped structure which is inferior border of the ventricle anterior to caudothalamic groove. This is your caudothalamic groove. So this is the caudate nucleus, this is the thalamus, and this is a caudothalamic groove. This IVH you could able to see anterior to your caudothalamic groove. That is where you can identify coronal and sagittal view of IVH. I already discussed about the screening protocol. The classification, as you know, also there are two classifications. One is a Papill's classification and one is a Volpe classification. The Papill's classification, which is a CT scan based classification, which is a grade 1 IVH, which is confined to the germinal matrix. Grade 2 hemorrhage, where the hemorrhage germinal matrix plus ventricular without dilatation, while grade 3 hemorrhage is a ventricular dilatation with a bleed into the ventricles, and the grade 4 ventricles is adjacent periventricular white matter with the bleed. That is what they are to called as grade 1, grade 2, grade 3, and grade 4 as a parenchymal bleed. While the Volpe's classification, which is 1989, which has termed as a general matrix hemorrhage, less than 10% of the ventricular area with the bleed in parasagittal area, while grade 2 is 10 to 50% of the ventricles with the intraventricular bleed. Grade 3, more than 50% of the ventricular area with dilatation of the ventricles. And they have mentioned as a separate entity, which is called as a periventricular hemorrhagic infarction. As you all know, this periventricular hemorrhagic infarction is nothing but the venous infarction. There is a compression of the vein, and that vertical vein compression leads to the infarction, and that is called as the periventricular hemorrhagic infarction. We'll come to that point one by one. I just showed you images of this is the coronal grade 1, which is confined to germinal matrix, sagittal grade 1, inferior to the lateral, inferior to the ventricle, and at chorothalamic groove, that is grade 1. When the bleed in the ventricles, 10 to 50% of the ventricles are there. You can say the grade 2 IVH, you can see this one, this is a coronal view and the sagittal view of the grade 2 IVH. When this bleed is more than 50% with the dilatation of the ventricles, that is called as the grade 3 IVH. While the periventricular hemorrhagic infarction or the venous infarction, which is a compression of the vein and leading to the fan shape area, which is echogenic area, onto the white matter, that is called as a periventricular hemorrhagic infarction. So this is a classic picture of echogenicity. The ventricles are obliterated and there is a fan shaped structure, which is also because of the venous infarction. As we all know, the grade 2 and grade 3 chances of ventricular dilatation, grade 2 has 5 to 10%, while grade 3 has 20 to 50% of dilatation. Mortality in grade 3 is 10 to 20%. Outcomes are bad as per the cognitive and motor development, 30 to 40%. But when it comes to the periventricular infarction, high mortality and high morbidity. And hence, the ultrasound helps for screening, monitoring, prognostic and diagnostic purposes of intraventricular as well as intracranial hemorrhages. Let's say the second thing, as once you see grade 2 or grade 3, you need to monitor that ventricular size. And the monitoring of ventricular size is done by the various indices. The first index is what we call as a ventricular index, or which is called as the Levin's index. So Levin's index is from midline to the lateral wall of the lateral ventricles. So these are the ones you measure for the expansion of the ventricles laterally. So this is how you measure into the coronal view and foramen of Monro view. So these are the lateral ventricles. This is the third ventricle and the foramen of Monro you could able to see here. So this is the Levin's index. We have a chart available for Levin's index. So for the chart, remember, post-conceptional age from 28 to 36 weeks. For simplicity, remember the values 10 and 13. So when you have any value more than 13 at any gestation, we are in trouble. We are in problem because this is the 97th centile of the ventricular dilatation of the Levin's index. We also have an action line that is called as intervention line. So the intervention line, what we just saw as a 10, and we also saw 13 millimeter at a 97th centile. Any given time, if this is more than 4 millimeter, that means 10 plus 4, 14 millimeter at 28 weeks, and the 13 plus as well as left side, your ventricular areas, which is a right and left Levin's index, ventricular index. Those things we need to document on charts. The second parameter is anterior horn width. Anterior horn width is basically, you can see from both the walls, which is the maximum part of dilatation of the anterior horn, where you could able to measure anterior horn width. There is a third parameter, which is a thalamus. This is a thalamus thalamo-occipital distance. This is the third parameter where ventricles are posteriorly dilated. You can measure these ventricles by thalamo-occipital distance. What are the values for those ones? We'll come to that. And the fourth value is a third ventricular width. Again, the foramen of Monro view. In the coronal view, you can measure the third ventricular width. The definitions you need to remember that ventricular index 4 millimeter above the 97th centile. I already told more than 11 millimeter below 30 weeks is a problematic. More than 14 millimeter at 36-38 weeks is problematic. At any given time above 14 millimeters, you need to be careful, and you might have to do the further involvement of your neurosurgeons. Anterior horn width more than 4 millimeter, thalamo-occipital distance more than 26 millimeter, and third ventricular width more than 3 millimeter. So these are the values you need to remember, and you need to document in your file when you are monitoring post-hemorrhagic hydrocephalus. And these are the outcomes part. I think it's given in the most of the books, so we all know these ones. The next condition which we monitor and screen is a PVL. Periventricular decomalacia. As you all know, the prematurity, hypertension, infection, and hypocarbia, these are the major culprit for the PVL. And hence, all the babies who are preterm, those who are less than 1.5, we need to screen for PVL at 4 to 6 weeks. If you find your cystic lesion before 2 weeks, it's antenatal insult. After 4 to 6 weeks is a postnatal insult. Where to see? You would be able to see the cystic changes. These cystic changes, you will be able to see superior to the lateral ventricles involving your frontal, parietal, and occipital area. So these are the areas where you will be able to see your lateral ventricles, mainly frontal and parietal, and extended to posteriorly, which is occipital area, where you could able to see the cystic lesions. On the coronal view, that's what we saw. This is the parasagittal view, which is just above or superior to your lateral ventricles at frontal, at parietal, and occipital area. What we have seen, these are the sites you need to always document, and hence the sweeping of the ultrasound is very, very important, from midline to right side, back to midline, and then going to the left side. All the areas has to be covered and documented, right as well as left. Grades of PVL, as you all know, the DVRs has 4 grades. Transient periventricular echodensities persisting more than 7 days. That transient converting to a small cyst, that is a grade 2. Now the evolving cyst, which is extensive periventricular cystic lesions, that is a grade 3. When the cysts are involving the white matter, that's a grade 4 PVL. So we have to categorize grade 1, grade 2, grade 3, and grade 4. Some of the examples, you can see the echogenicity, which is more than 7 days. These are the echogenicities which are more than 7 days. Periventricular echodensities which are persistent, that is a grade 1. When those echogenicity turns out to the cystic lesions, these are the cystic lesions, that's your coronal view, and parasagittal view, they are turning towards the cystic lesions, that's a grade 2 PVL. When they are extensive, you can see this extensive lesion, you can see these extensive lesions which is converting into the large cyst, they are called as a grade 3 periventricular echodensities. These are the grade 3 one. While grade 4 is extensively into the white matter. I don't think you require a radiologist here. A massive extensive picture of grade 4 lesions involving the deep white matter. Another example of involving deep white matter along with the dilatation of the ventricles in this baby. So such pictures you do see the babies who are micropremy, less than 700 grammer, and those who have prolonged ventilation with hypocarbia, with associated hypoxic changes. So be careful. We don't want such babies. We have to be very, very careful. Next part, we'll just discuss about cerebral Doppler. The Doppler is very useful in the neonatology. Now, what are the things we do in the Doppler? For the Doppler, we take midline sagittal view. Once we take a midline sagittal view, we put a color and we get this anterior cerebral artery. On the anterior cerebral artery, once we put a Doppler, we get pulse Doppler, we get this waveform. And this waveform we document as a peak systolic and diastolic. And then we get RI, the peak systolic minus end diastolic upon peak systolic. That's the value of the RI we get. The every ultrasound machine has a software, and they give you immediately RI value. If the ultrasound machine doesn't have software, you can calculate very simple formula as a peak systolic minus end diastolic upon peak systolic, and that is RI. The normal RI is 0.75 plus minus 0.08. So remember, any RI less than 0.6, you are in trouble. More than 0.9, you are in trouble. RI is very useful for babies like asphyxia, for hydrocephalus, and for diagnosis of PDA. Some of the RIs I'll show you. This is the RI. You can see that now the systolic and diastolic, this end diastolic has actually effect like a vasodilatation. So there is a more blood flow here, and this is a classic picture. This is a classic picture of your low RI of asphyxia. If your RI after 24 hours, between 24 to 72 hours, your RI is less than 0.5, that is one of the bad prognostic marker in cases of hypoxic ischemic encephalopathy. So this is the one example. This is another example which was showing, it was showing absent, but this is the classic example. You can see there is a reversal of the Doppler, and this is showing in the form of high RI. Because the diastolic is absent or reverse, the RI value will be 1 or more than 1. And this RI you see in cases of PDA or hydrocephalus or late onset sepsis. So this is the high RI. Now let's see another case. This is the 36-weeker, which is outborn, 2.5 kg, with a distress, with a poor perfusion, with a large liver and tachycardia. This is the echo picture of this baby, which is showing severe TR. A lot of you are doing functional echocardiography. So this is a classic TR, and you can see now in this classic TR, this is the measurement of the pulmonary pressure. By Bernoulli's equation, pulmonary pressures are turning out 42. Because this baby has a pulmonary hypertension, we were not knowing the cause. We also did this baby has the cranial ultrasound, and this baby's cranial ultrasound showed there is a mass. This is the coronal view. These are the ventricles. Can you see these ventricles? And this is a mass. And this is the parasagittal view, which with the mass. When we saw the mass, we did put a color Doppler in this mass. And this color Doppler shows that there are draining of the vessels here. And this is nothing but AV malformation. So the pulmonary pressures were high, baby was distressed, baby was in failure. Because of this AV malformation, immediately interventional radiologist was involved, and the baby has required further management. So this case has taught us that ultrasound is useful for diagnosis, ultrasound is useful for therapeutic purposes, and for the monitoring purposes also. This is the book which our team has written. This is the Atlas of Point of Care Neonatal Cranial Ultrasound. Those people who want, they can send a WhatsApp or email, and we are happy to forward the soft copy of this book, and you can utilize this book for the learning purposes. The next case now, let's discuss about this case, which is an unregistered term baby with a severe respiratory distress, with a prolonged capillary refill time, and severe metabolic acidosis. Functional echo showed increased cardiac output. The cranial ultrasound is normal, and let's see the lung ultrasound in this baby. This baby's lung ultrasound shows there is a hepatization of the lung, and already I showed you a picture of this baby. This baby has a straight shine, this baby has a sympneumonic effusion, and this baby has the collection of the fluid. So collection of the fluid with hyperechoic air bronchogram. You can see these hyperechoic structures here in the lung. So the lung looking like liver with hyperechoic structure, which is air bronchogram. This is the consolidated lung. This is pneumonic effusion in this baby. So naturally the diagnosis of the pneumonia made by the lung ultrasound picture. And ultimately, you could avoid a lot of X-rays in this baby by doing the ultrasound monitoring. Another case, a 35-weeker, 1.8 kg, baby not cried, baby required immediate delivery room intubation with hypotension, with perfusion problems and acidosis. The functional echo showed severe LV dysfunction and decreased cardiac output, and hence this baby's lung ultrasound done. And the lung ultrasound at the level of the diaphragm into the axillary region shows lung, liver and kidney. This is the normal picture of the lung ultrasound which is done at the diaphragm level. What this picture showed here is a collection of the fluid. So you can see this fluid collection in this one, and in this baby, if you see, this was a massive fluid collection. So this baby has the massive pleural effusion after the birth of the baby. And you can see in this again same picture of the effusion. And if you see this picture with the video, that this baby has a large amount of the fluid collection, and the baby required ventilation because the lungs were depleted. There was a compression because of the fluid. This baby required immediate diagnostic and therapeutic tap. Immediately, baby out to be the chylus, and those are 100% lymphocyte. So the diagnosis of chylothorax has been done in this baby on the basis of the lung ultrasound. Immediately the treatment has changed and the outcome of the baby has changed. Baby was in the NICU for almost 3 to 4 weeks, requiring octreotide. So how the lung ultrasound is useful for when the baby was deteriorated immediately after the birth, required intubation, ultrasound immediately helped for putting the drain and therapeutic fluid also, and then future management also. So remember, the lung ultrasound is useful for diagnosis of the conditions like RDS, TT and meconium. Lung ultrasound decides whether this baby requires surfactant therapy. Lung ultrasound also decides the future assessment of the baby's lung condition. We just saw the baby's condition like pneumonia, effusion, diagnostic taps and therapeutic taps. We will also see in future lung ultrasound when there is a baby suddenly deteriorated, and diagnosis of pneumothorax. We already saw the pleural effusion component. So just 10 minutes about the basics of the lung ultrasound. So the lung ultrasound is nothing but the soft tissue of a pleura and the air, which is the lung, which is the reflection. So it is nothing but the pleural reflection. It is the artifact produced by the pleura, and that is how the lung ultrasound artifacts we will see in the various pictures. To have a good lung ultrasound pictures, you should be using the linear probe, and the frequency preferably 10 or more than 10 frequency is ideal. So I would suggest when you are planning to buy a machine, portable machines are useful, but if you have more money, you can buy a big machine and 2 ultrasound probes. One is a sector probe, preferably between, if it is available, 8 to 12 probe is good, so that you can cover all micropremise, and the linear probe with the frequency of more than 10. If you are putting more lines, then hockey stick probe is also required, but that component is additional cost. Naturally, the lung ultrasound, you can have the various sectors, mainly the perpendicular and horizontal scans. What you can see, the perpendicular scans are the ones, and go ahead from that one. You can have sectors as in the form of 1, 2 and 3. That means anterior chest, anterior side, the axillary side and the posterior component of the lungs. It can be divided into the 1, 2 anterior, 3, 4 axillary and 5, 6 as a posterior component of the lung. And you need to document each component of a right and left also when you are putting the report. This is the normal picture of a grayscale anatomy of the lung ultrasound. The pleura, which is the parietal pleura and visceral pleura. Pleura producing the lines, A lines and B lines. I'll come to that point in the picture, the next picture which will show you. So this is the picture of the lung ultrasound. How this looks like on the grayscale ultrasound. This is the skin and soft tissue. That's the echogenic material, which is the rib and intercostal muscles. And then you see this echogenic structure. this echogenic structure, which is a pleural line, and below that, these are the artifacts produced by the, a shadow produced by the pleural line, and then I will discuss those ones. So this is the one first thing. Remember this echogenic structure. This is what? This is the pleural line. So the pleural line is a normal, smooth, regular, hyperechoic line. That is what first structure we need to identify on the lung ultrasound is the pleural line. Then you need to identify after the normal lung ultrasound, once you identify the pleural line, you identify the A lines. So these are the A lines. The A lines are the artifacts produced by the pleural line. They are also echogenic, they are horizontal, and they are equidistant to each other. Once you see the air lines, that means you will say that air is there in the lungs. That air could be physiological or pathological. That's the importance of our A lines. This is the B line. So the B line arises from the pleural line again. So that's a pleural line. First, always identify the pleural line. Then you identify these vertical laser hypoechoic lines. They remove your A lines. So they erase the A lines. They are called as the B lines. They move with your lung sliding. When the pleura is sliding on the lung, their lines also move, and that is basically the most important aspect we need to see. The B lines is nothing but alveolar gas liquid interference. Absent B lines are absent in the children and the adults, while the B lines are present in the normal newborns, mainly in the first 48 hours of the life. Preferably they disappears after 24 to 36 hours. As we know, there is a lung fluid absorption. So that is how the reabsorption of the fluid, what we call, and that is what after 48 hours, we don't see the B lines. What is the comet tails? So once you see the pleural line, this is a pleural line, and that's the B line. The comet tails, the comet tails are short path reverberation artifacts. These are the short. They are not till the end of the picture. They are short, they weaken with each artifact. They are small, they are vertical echogenic, and they rapidly fade away. And they resemble like a comet tail, hence it is called as the comet tail. So they are also present in the normal lungs in the first 24 to 48 hours. What about the next condition, what we call as alveolar interstitial syndrome, which is AIS? When you have more than 2 B lines in the lung field, can you see? 1, 2, 3, 4. These are the ones, they are called as alveolar interstitial syndrome. And naturally, it involves your more intercostal space, which is more involved. Now let's compare these three things. One is B line, one is called as a confluent B line, and one is called as AIS. So the B lines, as we discussed, they arise from the pleural line. They are vertical to the pleural line. Confluent B line means combination of entire space, combination of the B lines and entire intercostal space becomes as a one, that is a confluent B lines. When they are more than 2, that is called as AIS. That means you have more than 2 or 3 confluent B lines, that is called as alveolar interstitial syndrome. These are important factors, documentation. What is a double lung point? The double lung point is that means upper lung field is different and lower lung field is different. You can see this picture where this is upper lung field. Upper lung field pleura is showing the A lines, while the lower lung field, the pleura is showing the B lines. And this is the classic picture of transient tachypnea of newborn. And this picture disappears after 36 to 48 hours. To diagnose this TTN, you need to first confirm the double lung point and second ultrasound to confirm disappearance of the double lung point. And that is very easy to document, and hence you can avoid too many X-rays also here. What about RDS? I think day to day you will be able to see a lot of these whiteout lungs. So whiteout appearance with thickening of the pleura, thickening of the pleural line, and These are called as subpleural. These are subpleural consolidation. So these are the cardinal features of RDS. When you see the actual video, you will be able to see the air bronchogram also. So alveolar interstitial pattern with air bronchograms, with subpleural consolidation, a thickening of the pleural line, these are the cardinal features of the RDS. And lots of papers on the RDS, lots of paper on the diagnosis. Now, if you see the papers publication, there were 4 papers till 2000, there were 44 papers till 2016, and now the papers have increased to 120. In the last 4 years, there are so many papers on the lung ultrasound. This is a famous paper by Raimondi, which they have mentioned 3 patterns of the lung ultrasound. The first pattern they labeled as the type 1 pattern, which is a full hyperechoic image of the lung field or white lung field. The type 2 pattern they have mentioned as a B-line pattern. And the type 3 pattern they have mentioned as a predominance of the A lines, which are horizontal to the pleural line. On these 3 patterns, which baby requires the support or oxygen, they have documented. And what is the findings? That the babies with a type 1 pattern, all babies require admission with oxygen therapy. Almost 75% babies require CPAP and 25% babies require the ventilation. While type 2 pattern, only 10% of the babies require NICU admission with oxygen therapy. While not a single baby required NICU admission, that is 0% of the babies require NICU admission with a type 3 pattern, that is A-line pattern. And they have mentioned positive predictive value of 100% and NICU admission documentation by 97% by this admission. So it's very easy. You require maximum, once in expert hand, you require maximum 2 minutes to scan the lung and document all these patterns. Now let's see the lung consolidation. We already saw a few pictures of lung consolidation, but the few cardinal features of the lung consolidation are hepatization of the lung, air bronchograms, Schneid sign, and pleural fusion. These are the cardinal features of the lung ultrasound. So you can see the axillary view. You could able to see the liver. This is the diaphragm and the lung. So the liver and the lung looking like same. That is called as hepatization of the lung. And you can see in between these are the air bronchograms. So these are the echogenic structure. These are the air bronchograms. And this is called as the Schneid sign, which is the boundary between consolidated lung tissue and the aerated lung tissue. That is looks like a shred, and that is called as the Schneid sign. And that is also very important feature of the lung ultrasound. So this is the picture. You can see air bronchogram. You see these echogenic things which are moving along with your lung picture. This is also, you could able to see here some fluid here. This is a pneumonic effusion. This is the Schneid sign, and that's a consolidated lung in this baby, which are the video pictures of the lung consolidation. Let's discuss about the pneumothorax. The pneumothorax is a features in the form of the lung sliding, absence of lung sliding, absence of the B lines, presence of the lung point, and barcode sign. These are the 4 important features to diagnose the pneumothorax. So let's discuss one by one. Each baby, when you do the lung ultrasound, there will be the sliding. It will be the sliding of the pleura on the lung. So this is the normal features. Once you see the lung sliding, that rules out. So this is the pleura and this is the lungs ultrasound. That rules out your pneumothorax. The second point is a lung point. The lung point is a transition point where your B lines and then A lines, that point is called as the lung point. Can you see? This part, upper part is with the B lines and this lower part is with the A lines, and this is the lung point. And you could able to diagnose also here the lung sliding on this slide or lung sliding absent, and that's where both the side area of pneumothorax you can able to diagnose. So this one on this side and this one on this side, these are the 2 lung points in this picture. So that is called as a lung point. So the presence of the lung point is a confirmatory point for the pneumothorax. You can see this video. This is the B line picture, A line pattern, and you can see there is absent lung sliding here, while the lung sliding is present in this video, and this is the lung point. So this baby has a pneumothorax. We need to drain pneumothorax on the basis of this lung ultrasound picture. The next line is called as the seashore sign or sandy beach sign, and abnormality is called as the barcode sign. Let's see what these signs are. When you put a M mode, so this is the M mode. If I put a M mode on this picture, normally I will see the upper part is like waves on the beach, and the lower part is called as a sand on the beach. So this is called as a normal picture of the M mode of the lung ultrasound, and this is called as a sandy beach sign or the beach sign. So this is a normal M mode lung ultrasound picture. If the lung ultrasound picture shows like this, that means once you put M mode onto that picture and that is showing uniform tracking, this is the uniform tracking. This is because there is no pleural movement, and this looks like a barcode, and hence it is called as a barcode sign or stratospore sign. So this is how it looks like as on the lung ultrasound. This picture you can see the normal, abnormal, normal, abnormal. So the normal seashore sign, abnormal barcode sign, normal seashore sign, abnormal barcode sign. So this is a classic picture of the normal and abnormal, and we need to document this in cases of the pneumothorax. What is the sensitivity and specificity of the lung ultrasound when you compare to the X-ray? Can you see the sensitivity ranging from, for diagnosis of pneumothorax, sensitivity is 85%, specificity is 99%, pleural effusion 94%, specificity is 98%, consolidation is 95%, specificity is also 95%, pulmonary edema is 97%, 98%. So the lung ultrasound in various parameters, it is superior to chest X-ray. So eventually now we are shifting, day by day, we are shifting from reducing the number of X-ray and shifting to the lung ultrasound. I would say this protocol is important. This protocol is called as a SAFE protocol. This protocol is to diagnose 3 important conditions in emergency when the baby suddenly collapses. When you have the baby collapse, you do the left parasternal long axis view and immediately find out the myocardial dysfunction. If it is there, you need a full echocardiogram. In this view, you need to diagnose immediately cardiac tamponade. If it is there, you need to immediately drain. But if cardiac component is not there and you have lung sliding is present, you can diagnose the effusion, and then also that effusion requires the drainage. So here you are diagnosing cardiac tamponade, you are diagnosing the effusion, but if there is no lung sliding, find out the A lines and find out the B lines. If there are only A lines and there is no B lines, find out the lung point. If they are there, that means there is no lung sliding, there is a B lines at some point or lung point diagnosed and A lines only, and the lung point is diagnosed, that baby confirmed pneumothorax, that requires drainage. So these are the 3 major conditions, which is a SAFE protocol you need to follow when the baby suddenly deteriorates. This is the book which is coming out in the month of May, which is Atlas of Point of Care Lung Ultrasound. Once it is ready in the PDF, again, you can contact to our team and we will forward to you guys as a point of care lung ultrasound atlas. This has 200 pictures of atlas. We will forward to you guys. Now let's see the next cases. This is a 27-weeker 800 grammer. This baby required the CPAP delivery room. In the NICU, the baby has required Ensure, functional echo done, which is a PDF, and required the Brufen therapy. Baby was stable. Baby reached full pits on day 11. But baby has deteriorated day 10 to 2 of life with distension, apnea, bradycardia, hypotension, intubation. Naturally, the diagnosis comes in your mind and hence immediately functional echo done, which shows increased cardiac output. Along with this one, we did a abdominal ultrasound. And you can see this one, this echogenic structure, which is again echogenic structure, tree-like structure. This is nothing but air in the portal vein. So this is a classic example of this picture, which is air in the portal vein. Along with this air, you can see this fluid here. So this baby's picture, there is a air in the portal vein, there is a fluid, and you can see the X-ray. You can correlate this X-ray. This is the NEC X-ray with the portal vein, with a soap appearance. Naturally, this baby required with the perforation. This baby has a perforation. This baby required immediate attention. So ultrasound has helped in diagnosis of a portal vein gas. Ultrasound is very useful in diagnosis of ascites. Ultrasound is very also useful in diagnosing intestinal motility, which is coming out in a good way. The next case, this is unregistered term baby with a severe oligohydramnios, with a baby born in distress, immediately required intubation in delivery room, hypotension, poor perfusion, baby has a large lump in abdomen, functional echo shows severe pulmonary hypertension. So along with that, the immediately abdominal ultrasound saw. Abdominal ultrasound shows kidney with multiple cysts, and this baby turned out to be a polycystic kidney disease. Here we are not radiologists, but just immediate diagnosis. You got some additional factor, and hence you could able to pinpoint that this baby has polycystic kidney, and you can able to further prognosticate from the diagnosis. So this is the recent guidelines published in the just now in February 2020 by European Society, and they have mentioned that point of care ultrasound is very useful for diagnosis of pre-fluid. Point of care ultrasound is very useful for drainage and aspiration of the fluid. These are the 2 points they are strongly agreed: pre-fluid diagnosis and drainage and aspiration. They have agreed that ultrasound may detect in future parenchymal changes in abdominal organs, may detect obstructive uropathy and peristalsis and signs of necrotizing enterocolitis, but that is a future which is in the abdominal ultrasound. So we saw the cranial ultrasound, we saw the lung ultrasound, we saw the gut ultrasound. Let's say some points about the lines, procedures, and the research. So as we all know, seeing is believing. So ultrasound we want to see while performing the procedures. Once you have confirmed, once you've done your UVC or endotracheal tube, you confirm by immediate seeing that endotracheal tube position, UVC position. You don't have to wait for your X-ray, because X-ray in a good setup also takes minimum 5 to 10 minutes, while the ultrasound takes 1 to 2 minutes. Ultrasound is also useful for insertion of lines. It is useful for procedures. We'll come to that point. So you can see this picture which shows ultrasound endotracheal tube position is too low. UAC position is too low, while here UAC position is into the left atrium. Can you see? You can measure and you can pull out your UVC from that left atrium. So this is the video. This is short axis view. You can see this is the RA and this is LA, and this UVC is in your LA. Again, you measure from this point to this point. This one you require removal of your UVC. The second picture, UVC is subcutaneous. After 5 centimeter, UVC was not going, and this baby's UVC is not in ictu UVC. It has perforated and became as a subcutaneous. So that is useful for diagnosis. As UVC subcutaneous, immediately you need to remove this one. The ultrasound is useful for the PICC line insertion. The commonest thing is that here identification of the artery and identification of the vein. Once you put a Doppler on the artery, you will see the pulsation, systolic and diastolic. While you put the vein, you will see the plain flat, the hump-like picture. So you could able to identify artery and you could able to identify vein, and hence you could able to proceed your PICC line insertion. In this one, it is useful. So again, European Society has showed that the line insertion, the PICC line, that means IJV, subclavian vein, and the catheter tip position, they are strongly agreement that ultrasound is very useful for IJV, subclavian and femoral line, while ultrasound is very easy for catheter tip position diagnosis. These are the important points that we need to follow. Now you can see this is the only days before, just now on 31st March, you can imagine this picture, this is the heart, and you can see the heart pumping, which is compromised, and with a massive fluid. This baby came in a shock. Immediately, for the shock purposes, just put a probe, and you can see massive pericardial fluid here. Massive pericardial fluid, and this is the picture of the post-pericardial tap. So, immediately diagnosis of the pericardial effusion, immediately for drainage of the pericardial effusion, this is ultrasound is useful for as a therapeutic pericardiocentesis. I already mentioned about the therapeutic pleural effusion. Ultrasound is useful for diagnosis and therapeutic purposes. Similarly, ultrasound is useful for diagnosis of ascites and putting your drain, ascitic drainage is very, very useful. The simplest way is for bladder confirmation. I think this is a simple way and very useful way. A lot of time you say that decrease urine output, but while this patient could have a large bladder with a lot of urine, in such scenario, there is not decrease urine output. The bladder, there is a lot of urine is there, so you need to just drain that one. That is so simplified. You can confirm by ultrasound. It is just matter of 30 seconds. So we just saw that the full picture of ultrasound for cranial ultrasound, lung ultrasound, gut ultrasound, for the lines, for the procedure, few of the research. I think a lot of we saw already the research related to the cardiac output in late onset sepsis, abscess in late onset sepsis, RI in late onset sepsis, point of care ultrasound in late onset sepsis. Similarly, we are 4-5 research are going on basically on the term HJ babies and RI in the pre-exchange and post-exchange, RI in a stable babies. Those are the few research currently going by our team. This is the RI in a stable baby before and after pack cell transfusion. That's what our team has done, which is in the publication area now. This is another area which our team has designed. When the baby deteriorates, what are the things you will be useful for sudden deterioration and what are the things you will see in the cardiac ultrasound? The structure, effusion, cardiac output, filling contractility, and pulmonary systemic pressure. For the cranial ultrasound, intraventricular, intracerebral, and cerebral hemorrhages and velocities you need to document when the baby deteriorates. For lung ultrasound, immediately diagnose pneumothorax, effusion, and consolidation. For abdominal ultrasound, find out free fluid, find out intraperitoneal portal vein gas, bowel wall gas and AC signs, bladder size, filling, and kidneys. And for line position, correct position, pericardial peritoneal effusions. This is the chart which was produced by Professor Martin and myself, and this is what the CCPU is following in Australia, that when the baby is suddenly deteriorated, and we are working on that one. So dear friends, we saw the ultrasound various roles in day-to-day practice, but it is not so easy. It requires proper training. It requires proper accreditation and ownership. At present moment, lot of units, they are gaining experience in India, and now it's time to achieve the competency. So there is induction, gaining experience and achieving competency. And that's where all the fellows need to have a proper mentors, and each unit should develop this proper training. And that's where we need to go ahead for the future. Australia started the CCPU in 2007. The Canadian Society started in 2011. The US has also started in 2013 after their various discussions. And European Society, as already you know, the guidelines turned out to be 2014 and 2015, they have a few guidelines. The Indian team, along with Dr. Mohit sir and Dr. Tushar Parikh sir, we are conducting a lot of point of care neonatal ultrasound training workshops. So far, so we conducted 47 workshops. Our last workshop was in Mandalay, Myanmar on 1st and 2nd February 2020. So these are the training workshops we are conducting, but I must say that workshop is just for stimulation. Workshop is just induction. We need more practice, and hence Indian team is preparing this year the protocol by IAP and NNF as a full course of the ultrasound training. These are the review articles written by our team. This is point of care neonatal ultrasound for head, gut, and lung. These are the lung ultrasound article in Journal of Neonatology. This is a cranial ultrasound article in Journal of Neonatology. Those who are interested, they can go through these ones. This is the book, which is a point of care neonatal ultrasound and neonatal cardiology, written by our team. To get this book, we don't have PDF at present moment, so you need to contact Mohit Sani sir, and that's his mobile number. You could able to gain the book from him, and after the Corona episode, he could able to courier the book to you guys. This is the YouTube video available by the American Society, which is along with the Sonosite, which is available on the YouTube on point of care neonatal ultrasound, and that's a shorter format. This is a longer format lecture what we have done today. We have done survey in India about the ultrasound and Indian NICUs. The good news is that almost 75% of the level 3 NICUs have ultrasound machine. That means machine is there, people knows the role also there. Now almost most of the people are doing echo and cranial ultrasound. Now, time to gain lung ultrasound, gut ultrasound, and line position also. So these are the areas which are picking up, and hence we need to go ahead and work on those additional components. What are the limitations? I think you all know the biggest limitation at present moment is the PCP-NDT in Indian perspective. How to overcome this PCP-NDT? What are the requirements of the PCP-NDT? Mainly the requirement is your certification. So those people who are working in tertiary centers, under your mentors, you need to have a 6 months training certificate. So if you're doing neonatology or neonatology, along with your additional certificate, take a certificate from your mentor that during the course of DM or DNB, these people who are trained as a bedside ultrasound and they're allowed to do the neonatal heart, neonatal cranial ultrasound, neonatal lung ultrasound, and abdominal ultrasound. That certificate is useful when you apply to your local municipal corporation, because local municipal corporation will go through your degrees and this certificate. Ideally, a person who is MBBS with 6 months of training of ultrasound, they can able to do the ultrasound. So, along with your certificates, this certificate is helpful. So, I will request all the mentors to provide this certificate to your fellows, and that will be helpful. When you apply, make a good friendship with your local municipal corporation people, because they don't understand about role of ultrasound in neonatology. Teach them, tell them that this is not for obstetric ultrasound, and then they will understand. Then they will give certificate to you. Once you get a certificate, then you apply for the ultrasound machine. Once you get ultrasound machine, that means your name is registered with local municipal corporation. You need to submit monthly report to the local municipal corporation before 5th of each month without missing anything. If you miss, they are very strict. So every month before 5th, you need to submit zero obstetric ultrasound report and tell them that we have not done any obstetric ultrasound, only that you need to document that ultrasound. Documentation is very, very important. Whenever you are doing point of care ultrasound, in the file, you need to mention point of care neonatal cranial ultrasound, point of care neonatal cardiac ultrasound, point of care neonatal lung ultrasound, because you are doing bedside point of care. You are not doing structural ultrasound. Once doing this ultrasound, if you find some structural problems, suppose I find muscular VSD, involve your pediatric cardiologist. Suppose I found some PDA, involve your pediatric cardiologist. That is a better correlation between your pediatric cardiologist and pediatric radiologist. So they will also know that you are also working is a simultaneously trained. When you don't have facilities about the big guns, take a help of your mentors, involve them, send the pictures to them with the good videos, and then take help of them one. Ultrasound is highly operator dependent. It is not one day thing. When you do more and more, then you learn more and more. We ourselves started ultrasound since 2002 in Sydney, and now still we're also in learning phase. So remember, you are not pediatric cardiologist and you are not pediatric radiologist. We need to once find abnormality, please involve those people. That is most important aspect. So dear friends, we believe the portable ultrasound is a visual stethoscope of the 20th century. We believe that ultrasound is the future for neonatologists. We believe this ultrasound is a stethoscope and it's very, very important. So I think this is the most important slide from my side. This slide summarizes the role of ultrasound in neonatology. It is for critical assessment of pericardial tamponade, pleural effusion, ascites, IVH, pneumothorax, pneumonia. It is for screening and monitoring of IVH, PVL, hydrocephalus, PDA, PPH, and NEC. It is for procedures, pleural tap, parietal tap, suprapubic tap. It is for confirmation of the line placement, UVC, UAC, ETT position, PICC line position, and gastric tube feeding position. It is nowadays very, very important. A lot of research has been already done on SVC flow. Now time to do a lot of research on cerebral blood flow, SMA flow, or cardiac hemodynamics like tissue Dopplers or icon Doppler correlation. So I think ultrasound overall has a lot of aspects in our day-to-day neonatology practice. With this, I would like to stop here. Thank you.
Thank you, Pradeep. I think it was a wonderful lecture again, and I'm sure. Thank you so much for troubling you so much, but this has been very useful. To tell you the truth, there are 33 people who have attended the lecture again today. So
Oh.
it is in high demand.
Thank you. Thank you.
Thank you so much.
Okay. Thanks, Sridhar. Bye. Bye.